Right. I'm not getting into any HRT and estradiol and things. The one thing I've learned in life is the more you begin to learn, the greater you realize how ignorant you are. And I'm completely ignorant of all of this. I don't even prescribe HRT. I leave it all to you guys. But what I want to do is just show you maybe from the perspective of the type of patients that we get coming in. And these are real situations that have occurred. Looking at both ovarian and endometrial carcinoma and the approaches people have taken. A bit like you, most of our work is trying our very, very best to get the balance right and to counsel the patients as to what the balance is. And it seems very familiar or very similar to the use of HRT, where you're counseling, trying to get the balance right for them as best you possibly can. So here's a lady who's only 27, and she turns up to the clinic. She is the HNPCC carrier, very fit, intelligent young woman. And in the UK, these patients, where we get patients where there's a family history, we have criteria set down, and they will go to the genetics people. So we're very fortunate. We'll occasionally get patients ourselves. We send to genetics, but a lot of the time they will have been weaned off the system, and geneticists will start to give them probabilities of a variety of cancers that they may well develop. She's 2 children, aged 5 and 6, and she, with her mutations, her risk of endometrial cancer was 40% plus and 12% plus for ovarian cancer. And this is the kind of figures we'd receive from the geneticist. 12% plus is on the sort of 15%, if you like, risk where we would consider intervention. And we went through a variety of ways of seeing if we could protect her against her carcinoma. And the first thing I said to her was the oral contraceptive pill. And there's a variety of reasons to say that, even though she's got 2 children, that she does want to use some prophylaxis or some family planning. And I said, this is the one to go for. I've mentioned to you before about the prevention of endometrial cancer with oral contraceptive use, the prevention of ovarian cancer, but we don't know short term where it is. We do know kind of longer term, so I'm hoping that was a good idea. And of course, as we know, colonic carcinomas are also reduced in those who use the oral contraceptive pill. So I think that was giving her a little bit of something and a little bit of time to have a consideration of that. We then went through the screening options, and we've done that in the lectures and made it very, very clear to her that the actual screening for ovarian cancer is unproven. It is not really a way to go. And endometrial cancer, all right, annual scans, endometrial biopsies, irrespective of what the scan says. And the only evidence we have of that is a small cohort study where they suggested that might be the right thing to do. There was a trial with regards to the Mirena IUCD in HNPCC patients run in the UK. It had national support, and the concept was that patients would be offered the Mirena coil and to see then over X amount of years whether or not it developed any endometrial cancer. And that trial was shut because of failure to recruit. So one of the issues we have, not an issue in fairness, one of the circumstances that arises with these ladies is their desire to have everything taken out. And that's why we couldn't run that study. So that was shut down. So if we do a pelvic clearance, we know that we are going to reduce the risk of these cancers of ovarian and endometrial for these patients. And she went off and had a think about these options, and she came back and she was adamant she wanted the pelvic clearance, the lot out, and she's 27. So I don't know what you would do with this lady if I sent her to your clinic, because I don't know what to do with her anyway, and I am going to send her to your clinic. So what would people here suggest for this lady, by any chance? I mean, would you go to standard HRT here? Or would you use the oral contraceptive pill as a form? I'm asking the question because I don't know, there's no other slide, folks. This is it. I'm asking the question because I don't know the answer. So I'm not going to give you the answer because I don't know the answer.
So we all agree she needs some replacement, right?
Yeah. So we have to do something. I don't think we can leave her as she is.
She cannot stay without hormones, right? So I think the question is, what kind of hormones?
Has anybody any concepts here of what they would do? Considering what I told you in the lectures before, anyway.
I mean, I'd say that, you know, you could use either the HRT or the oral contraceptive, but we have some evidence from studies in women with premature ovarian insufficiency that HRT is actually better than the oral contraceptive, certainly in terms of bone preservation. And quite almost certainly, I would say, it's going to be better for the cardiovascular system as well.
Right, so you go straight to the HRT.
Yeah, because at her age, having, you know,
she's going to be on this for a while.
Becoming menopausal, she's going to be at high risk for both osteoporosis and for coronary heart disease.
Yeah, I think we've no doubt that something has to be done. We couldn't not do anything, but I'm just wondering what people do. Yep.
I agree 100% in the bilateral ovarectomy and hysterectomy, but we know from ROCA data published on urology that when women undergo bilateral ovarectomy before the age of 38, they have an odds ratio of 2.89 of having Alzheimer. So we have to look not only after estradiol loss, but as testosterone is so important in women, we show in the afternoon, that we do not consider the level of testosterone in the normal cycle are higher than estradiol. We never replace it. And with ovarectomy, we have a loss of 80% of total testosterone, plus the adrenal production of the HA goes down. So I think that the appropriate replacement here would be transdermal patch with estradiol with the level appropriate for the age, plus testosterone that we can give by cream, maybe we can discuss it in the afternoon, and the HA as well. Because otherwise, we will deprive half of the most important trophic and anti-inflammatory hormones that are testosterone and the HA in the woman as in men. So I think that the choice is absolutely pertinent as far as we know, but the replacement should consider all the hormones and not just estradiol.
And that's why I need people like you, because I haven't a clue about any of that.
Can
Testosterone, yep, got that.
Professor, because for me, I'm not really... if we give testosterone, do we still need to give the HCA?
Well, I will present, maybe I can add in the discussion, because there are beautiful data from Genazzani published showing which level of every children hormone you have according to the dose that you give of the HCA. So 10, 25 milligram, I will change my lecture and put it inside, so that we see what we can give back according to the level, and we remain in the physiological level. What is impressive from his data, so all published, is that you go up physiologically with all the children hormones, so to say all the steroids, and the only one that goes down, as I said, is cortisol. That is the marker of an increased risk of any disease, including cancer. So I think we should consider this. And the age of the woman is very young, so I will start with 10 milligram and then go to 25 and check the physiological levels so that I really give her the perfectly tailored dress. Also, we must consider that in a hysterectomized woman, the risk of breast cancer is reduced by 23% with the transdermal estradiol. So, we really are doing our best. In parallel, what I recommend very strongly is to have 1 hour brisk walking every day, because just by walking brisk, we can reduce the general inflammation up to 30%. And this will reduce the vulnerability, because we know that inflammation is the silent killer, increases in the vulnerability to cancer, to cardiovascular diseases, and to neurological diseases. So it's a comprehensive, but this was absolutely to be done, because genes were very threatening, so to say. But then empower this woman with all the hormones she needs, plus an appropriate lifestyle consultation.
She's probably doing the walks with 5- and 6-year-olds. I'm sure she's been dragged around the place.
Just to, I think for the audience, just to keep it practical, what if you give patches? What level of estradiol would be the desired? What level of serum level of estradiol
this young,
for this young?
I would go to at least 100
so
picogram per ml.
Okay.
I'm an oncologist, so I work a lot with young children who've been on treated for leukemia, for recurrences, total body radiation, and nobody pays attention to the fact that they didn't have even adrenarche. They were 7 when they had cancer. They didn't have a menarche, and they have lost 80% bone loss at 24.
Yes.
So disasters,
Yeah.
disaster. I mean, great that they are survivors of these cancers, but if we do not really take care
The
of all
quality
the
of
symphony
life,
of hormones they've lost, what's the point of this? They will die at the age of 40 by fracture or Alzheimer, or both, or serious cardiovascular events. So we really, and going back to your question to testosterone, I will add testosterone cream of vegetal origin with an FDA-approved dispenser, so I know exactly what I give back, and we have 4 different dosages, so I can really tailor it. And this is very important for the genital response, because if I have a 24 or 25 or 35 years old lady, I want to empower and sexual life, because she needs intimacy, she needs orgasm, she needs to feel alive, and the husband needs this as well. So really, we need to reconsider all these aspects with a serious oncological, as you did, treatment, but then it's back to our colleagues, like myself, who takes care of these patients so that they really go back to a full life, not a shadow life.
Yeah, I agree.
Any other questions? Dr. Samaras?
I couldn't agree more with Dr. Graziotti. Unfortunately, testosterone is something really highly misunderstood as far as women are concerned. I asked previously if we can use testosterone for the bones, and I think the answer I got is routinely we don't use it. The problem with testosterone is how you give it and what kind of choices we have in this country. I have the luck to have implants, so I can put them and I have no problem whatsoever. I improve highly the bone density immensely, and I improve very much the libido. But that's not the point. The point is, I don't really know, at least theoretically, what kind of what does testosterone has, what effect testosterone has on some kind of possible cancer risk. I don't know how to put testosterone in the breast cancer risk. I do know that testosterone is very vital, as the previous speaker said, for the well-being of the woman. Libido, it's an anabolic thing. It makes them feel great, and it improves highly her bone structure.
I mean, from the gynae-onc viewpoint, I'm not aware of testosterone being a problem at all. Yet we do have some testosterone-producing ovarian tumours, but usually benign rather than malignant tumours. So I'm not aware of anything out there whatsoever to worry about use of testosterone if you had one of the gynecological malignancies.
Dr. Vlachos knows some work done in breast cancer and testosterone
breast is different,
implants. Exactly.
Yeah,
in the hospital, in the university hospital.
I don't do breast cancer, that's one.
Yeah. But I mean, I think it's a big debate, and I think the problem is how you give it and how you measure it, and how reliable is your lab when you want to measure the levels. And I think we all should agree that if you want to have reliable levels, you should never use oral. Because oral, you go to the enterohepatic circle and you don't know what you measure, because you measure now and then half an hour later you have a different level. Only when you use gels or patches, magnifying patches, then you have some more steady levels. And I don't know, I mean, you guys are the endocrinologists.
I think the level should range above 20 nanogram and maximum 80 and not below 20. And I think they found it below 20, it's a postmenopausal level that affects the libido of the woman. I don't know if you have any other.
The point is that if we give the HEA, we have the most inter-equilibrium between different hormones. And yes, and the point is that, very particular for the HEA, that it is absorbed by the tissue you use, I explain to my patients. So for example, if I give you the HEA and then you exercise simply walking, your muscle picks up the HEA and transform in testosterone and estradiol, and this will translate into an increased synthesis of tropomyosin, myosin, actin, and so on, say the contractile proteins. If you use your brain because you are learning a different language or you are doing crosswords or whatever, your brain capture your neurons, and the glia capture the HEA, translate it, and aromatize it into estradiol and testosterone. So, and on the breast, it goes on the beta receptor, the HEA. The data we have, not my group, but other people published on the oncologist, very interesting. They had women with breast cancer already. They put the implants, so very high levels, plus gave anastrozole, and then operated 6 months later, and the bulk of the breast cancer was diminished on average by 50%. And now we will have researches on the hydrotestosterone, so the metabolite, just to improve at least the genital response and looking what happens in controlled studies, multicenter, on breast cancer. Because we must give back answers on that. If you like, I can have 10 minutes later and I'll present why, when, and how to give back testosterone. Very short.
I think we should go.
In my time, not in other time, but I can shift.
Any other question before we go on to Professor Panoskaltsis, who's going to give us our...
Just one point, Alessandra. First of all, in terms of DHEA, it's not generally available. Certainly in the UK, we don't have any preparations that are available, so we wouldn't use it. And if you're using estradiol and testosterone, I personally don't see that there's a great benefit in giving DHEA. I know you do, but I don't. The other point is the availability of testosterone for women. And that's a big problem because, you say you were giving testosterone implants. We can't actually get hold of testosterone implants anymore.
I get them from the States.
Yeah, we used to get them from the States, and that supply has disappeared as well. So the only option we have in the UK is using the testosterone gels, which are male preparations, and you just use about a seventh or a tenth of the amount you give to a man, and do it symptomatically.
We have pharmacists who are certified pharmacists surveyed by the National Health System, so they are authorized officially to prepare all these galenic preparations. They're tested in qualified, sterile rooms, blah, 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 blah. So very, very solid requirements certified by the National Health System, so we can have preparations titrated with DHA, 10, 25, 10, or 50, and this testosterone of vegetology titrated as well. Certainly it is accompanied by the pharmacist, but this is the only alternative I have to give exactly what I want and to test in the blood what I want.
But unfortunately, I can't send all my patients to Italy.
No, but you can have a certified pharmacist, I think, as well in the UK. I don't think it's so difficult to have this requirement. You don't have any possibility?
I think this is the same problem for us, but you're lucky, and I think we should probably see how we're going to get it.
You can always give gel by pump, actually, if you have a pump for gel, not the...
No, but specifically, I think the testosterone gel you can calculate because you can use a male preparation, then dilute it or take the portion. But for DHEA, I think it's it's very difficult to get it. At least in Greece, as far as I know. I think we should go on to the next speaker, and then when we have time, we can go back and.